Hey, good afternoon, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. So, again, I welcome you all in this channel and our new test series, which is NEET SS Pediatrics test series, which is divided into 72 subject wise or topic wise test. We'll discuss it later also. So, without further delay, let's start our discussion of. So today we will discuss important table discussion of Nelson-based renal system. This system is very important. Many question has been asked from renal system. So it is a part of NEET SS Pediatrics 12-week long 72 subject-wise test and 6 full-length grand tests. This test series 100% Nelson based, 100% exam oriented. So without wasting our time, we'll start with this discussion of diagnostic algorithm of journal approach of patient patient of glomerular extragranular hematuria. Basically, we are discussing hematuria here. Okay, so hematuria basically, just see if it is cola colored, if proteinuria is more than 30 mg per deciliter, RBC casts are present, and acute nephritic syndrome feature are there. This is classical glomerular hematuria. And if it is not, then this is extraglomerular hematuria. We have to remember. So basically, these are the investigation panels. We will discuss this. CBC, BUN, create electrolyte. We have to go for C3C4. ASO, anti-DNase B, ANE, anti-neutrophil antibodies. So these are journal guideline of investigation. But if hematuria is not having cola or brown color urine, no proteinuria, no RBC cast, we'll go step by step. This is very important because in exam they'll ask you the steps in this. Okay, so first step is urine culture. Okay, they'll ask the step 1 will be urine culture. Step 2 will be urine calcium create ratio, sickle, prep, renal ultrasound. So step 2 will contain these three. So they'll ask step 1, step 2. Step 3 is urine analysis of siblings and parents, serum electrolytes, and if urolithiasis is there, then 24 hours calcium creatinine ratio. If hydronephrosis suspected, then cystogram plus minus renal scan. So this is simple looking yet very important table. Okay, many questions will be asked. First, they'll ask which type of hematuria is there based on this. In glomerular hematuria, what are the investigation expected and what are step 1, step 2, step 3 investigation in extraglomerular hematuria. Very, very important. Next, we will discuss this important table. This table is a summary of acute glomerulonephritis. Okay, the various important causes like PSGN, which is we will discuss, IgA nephropathy, Goodpasture syndrome, and idiopathic rapidly progressive glomerulonephritis. Okay, all these we will discuss in a very comparative manner. Okay, so first thing first, age and sex. PSGN seen in all ages, but mean age is 7 years and the male to female ratio is 2:1. Okay, these all three questions are previous INISS questions. Okay, IgA nephropathy is 10 to 35 years of age, 2:1 male predominance is seen. Goodpasture syndrome is 15 to 30 years, 6:1 male, and idiopathic rapidly progressive glomerulonephritis adults and 2:1 male. Okay, acute nephritic syndrome seen in 90% cases of these syndrome, but IgA nephropathy, IgA nephropathy, acute nephritic syndrome found in 50%. Asymptomatic hematuria is the common complaint of IgA nephropathy, not the other one. Nephrotic syndrome. So this is independent question. What is the nephrotic syndrome percentage in PSGN? It is 5 to 10%, and in idiopathic rapidly progressive glomerulonephritis it is 10 to 20%. Hypertension, just see, PSGN it is seen in 60%. All the questions I am discussing are potential MCQs. IG nephropathy it is 30 to 50%. And idiopathic rapidly progressive glomerulonephritis it is 25%. Just remember the where I'm caution mark is there, it is ultra important. Okay, acute renal failure it is seen in 50% cases, but this was previous INSS question. Renal failure ARI in PSGN is transient. Okay. 50% in good posture and idiopathic rapidly progressive glomerulonephritis RPGN 60%. Okay. Latent period 1 to 3 week is there, we know, in PSGN cases. Pulmonary hemorrhage and iron deficiency anemia, they will give you clinical scenario and ask this question. So pulmonary hemorrhage and iron deficiency anemia are seen in good posture syndrome. Laboratory finding, again very important area to discuss. ASO titer increase in 70%. All values are important, especially in the case of PSGN. Positive streptozyme case in 95% cases. C3 and C9 will be down and C1 or C4 will be normal, again very important. In case of IgA nephropathy, serum IgA increase in only 50% or 100% of patients. IgA in dermal capillaries will be seen. Positive anti-GBM antibody will be seen in good posture and positive ANCA antibodies will be seen in RPGN. Okay, immunopathogenesis is not that important, but in light microscopy, diffuse proliferation is seen in PSGN, focal proliferation is seen in IgA nephropathy, and good posture syndrome, focal to diffuse proliferation with crescents will be seen. Similarly, with RPGN, crescentric glomerulonephritis will be seen. Okay, immunofluorescence is not that important. Electron microscopy is important, and it is previous NEET SS question. Subepithelial hump are seen in PSGN. Okay, mesenglial deposits are seen in IgA nephropathy. There are no deposits in progressive glomerulonephritis and good posture syndrome. What is the prognosis? 95% of PSGN resolve spontaneously, 5% of RPGN are slowly progressive. In IgA nephropathy, slow progression 25 to 50%, good posture 75% stabilized. Similarly for RPGN. Treatment we'll discuss in other time. So just pause this video here and revise all these marked things, because everything I have marked with caution. It is previous year question or expected question. So you can't miss these things because these are ultra important. Revise this part of video again and again, and you will get 1, 2, 3, 4 questions from this table are expected from your upcoming NEET SS or INSS exam. Okay, next we will discuss, okay, acute glomerulonephritis will diagnostic table we will discuss. Basically, if serum complement level, we will see if serum complement levels are decreased, C3 CH50 are decreased, or normal serum complement. So this question is frequently asked and a favorite for examiners. Lupus nephritis, subacute bacterial endocarditis, shunt nephritis, essential mixed cryoglobulinemia, and visceral abscess. So you have to remember these are the ultra important. Okay, so you can, and renal disease like acute PSGN, membrane proliferative GN, you can remember this as less MA. Okay, any mnemonic you can remember, but just remember these very ultra important. You can't miss which are the disease in normal serum complement levels are seen. Other condition in this normal serum component are seen. These less MA are serum complement decreased. Okay, in this scenario, serum complement level are normal. Systemic disease like PAN, hypersensitive vasculitis, good passer syndrome, renal disease like IgA nephropathy, idiopathic rapidly progressive GN, or and type 1 GBM, type 2, type 3, and post-infectious glomerulonephritis non-streptococcal. This was INISS question. So streptococcal PSGN is having decreased C3CH50 level, but in post-infectious non-streptococcal normal complement levels are seen. Okay. The next algorithm you have to see for ASO anti-DNase B titer streptozyme test. Okay, if the complement level returns after 6 to 8 week, ultra important, the diagnosis will be PSGN. If the complements are negative or failure of low serum C3 complement to return to normal by 6 to 8 weeks, then plethora of diagnosis will pop up in front of you. Important are lupus nephritis, essential mixed cryoglobulinemia, shunt nephritis, visceral abscess, MPGN, bacterial endocarditis. Again, look this simple looking diagram once again, and it is very important in this just to see in which condition serum complement level are low, and after serum complement you have to see if they return back within 6 to 8 weeks, your diagnosis will be acute PSGN, and if they are not returning back by 6 to 8 weeks, your diagnosis will be different. Okay. Next, we will discuss classification of lupus nephritis. Again, very important discussion. So, lupus nephritis class 1 is minimal mesenglial. There will be no renal finding as expected. Second, mesenglial proliferative. This is mild clinical renal disease with minimal active urinary sediment. Okay, mild to moderate proteinuria, but never nephrotic. Your question will arise in these type of second, third, fourth. Third is focal proliferative, less than 50% glomeruli are involved. Okay, in this more active sediment are there. Increased proteinuria more than 25% is nephrotic. Hypertension may be present. Everything I'm marking as a question is a potential question or previously asked question. Okay, some active lesions require treatment. The fourth, which is diffuse proliferative lupus nephritis, more than 50% glomeruli involved, all may be segmental or global involvement. Okay, more severe renal involvement with active sediment, hypertension, heavy proteinuria, frequent nephrotic syndrome, proteinuria will be seen. Fifth is membranous glomerulonephritis, significant proteinuria, often nephrotic with less active lupus serology. This is also asked. And advanced sclerosing lupus nephritis is more than 90% glomerulosclerosis with no treatment prevents renal failure. So please, I'm requesting you just again revise this classification of lupus nephritis again. So in this slide, these are the very important thing we have discussed. We have discussed the hematuria of glomerular extraglomerular origin. We have discussed acute glomerulonephritis differential diagnosis. We have discussed acute glomerulonephritis with serum complement level and further classification, and we have discussed classification of lupus nephritis. All these four tables are actually available as a test series format, and these are available at mobile app. We have launched Android app for this. Just check out the link and in description you can use the link and download the app and smoothen your preparation. Okay, next we will discuss quantification of proteinuria. That previously we have discussed hematuria. Now we are in proteinuria. Okay, so dipstick testing, it is routine screening. So what are testing interpretation? Basically you have to remember 1 plus, 2 plus and 3 plus, 30, 100 and 300. This is very important. Okay, false positive you have to remember. In these conditions false positive will be seen like if urine is very alkaline, pH is 8, very concentrated urine, and there is pus, vaginal secretion and semen is present. So these are the causes of false positive dipstick. In which condition false negative dipstick will be seen? In a patient with urine specific utility is more than 1.020. So these two questions will be very important. 24 hours urine for protein or create excretion. So this is actually quantitation of proteinuria. Okay, what is a normal range of 24 hours protein excretion is less than 150 milligram per meter square by 24 hours. So this is very important. Okay, so in this condition, you have to remember these the value 150 milligram per meter square per 24 hours. Sport urine protein create ratio, preferably first urine sample. Just remember these things, less than 0.2 milligram protein milligram per create is older than 2-year old and less than 0.5 milligram ratio in 6 to 24-month old. Basically they wants to say 6 months to 2 year it is should be less than 0.5 and more than 2 year this is less than 0.2, it is normal. Okay, so this is simplest method, but it is less accurate. Which is most accurate? This method, 24 hours urine for protein create excretion, it is most accurate. And microalbuminemia, okay, so less than 30 milligram urine albumin per gram, it is normal. Above this, it is microalbuminemia. So these are the important definition. These are frequently tested in exam. So just pay attention with these. Okay, now we'll discuss summary of nephrotic syndromes. We have discussed differential diagnosis of nephrotic syndrome earlier. Now we'll discuss nephrotic syndrome summary. The parts are minimal change nephrotic syndrome, FSGS, membranous nephropathy, MPGN type 1, type 2. Okay, I'll go through important point in this table. Note the table as a whole. So just see uh, 2 to 6 year of age group, 2 to 10 year of age group, and MPGN is 5 to 15. So basically MPGN is a disease of adolescence and uh, MCD and FSGS is disease of early childhood and membranous nephropathy is disease of uh, adulthood. Okay, so in everything male are more affected except MPGN. MPGN male and female are equal. You have to remember this. Nephrotic syndrome, maximum nephrotic syndrome seen in MCD and other things they will ask in membranoproliferative 60%. Asymptomatic proteinuria are also 0 in MCD and MPGN 1 and 2 it is 40%. Hematuria will be seen maximum in membranoproliferative. Hypertension, MCD they will ask, this is previous NEET SS PYQ. 10% cases of MCD presents with hypertension and 35% are in MPGN. Okay, so a rate of progression of renal failure, so generally it is doesn't progress. So this you have to remember. Associated condition is very important. If in question they are mentioning HIV, heroin use, sickle cell disease, reflex nephropathy, anything can be there in exam. Your answer will be FSGS. Renal vein thrombosis, SLE, hepatitis B, C, lymphoma and tumors, your answer will be membranous nephropathy. Partial lipodystrophy, your answer should be MPGN type 2. Okay. So, genetics will not discuss. Laboratory findings, nephrotic syndrome finding will be there. Burn will be increased in 15 to 30% cases. Normal complement levels will be seen in everywhere, but low complement level, this was INISS question. Low complement level was seen in MPGN type 1 type. Light microscopy will be normal in MCD. This was the question. And focal segmental sclerosis, as name suggests, focal sclerotic regions will be seen. Thickened JBM will be seen in MPGN and membranous type MPGN type 1 and this membranous nephropathy. Immunofluorescence, don't have to remember. Electron microscopy, subepithelial deposits will be seen in membranous nephropathy and dense deposit will be seen in membranoproliferative. And remission will be seen in 90% of MCD. I am going very fast due to time limitation, but you can pause the video and revise these important points we have discussed again, and you can rewind the video again. So basically, this is crux of renal. Renal system is very vast, so I'm discussing crux of it. Okay. Ultra important table, renal tubular acidosis. Okay, the classification of RTA is as proximal, classical and distal dysfunction. Just remember, distal dysfunction, the potassium will be high. Okay, this will be type 4 also. Urine pH is less than 5.5 in proximal. This is caution. In other things, it is more than 5.5. I am just highlighting cautions. Okay. Urine net charge is positive in proximal. This is NEET SS question, previous year asked. Fractional bicarbonate excretion, they'll ask this question also. This is more than 10 to 15% during alkali therapy, 2 to 5% and 5 to 10%. This was the again previous NEET SS question. Okay, U minus B PCO2, urine minus blood CO2 pressure will be normal in proximal, low in others. Response to therapy, it is less responsive, it is responsive and less responsive. Fanconi syndrome will be associated with proximal RTA, nephrocalcinosis is distal RTA, and renal insufficiency in distal dysfunction. So again, I'm requesting you all, this table is very important. Don't take these tables lightly because these are a direct question in exam. If you miss these tables, these will be up in an exam and you're not able to answer. So in this slide, these we have discussed hematuria, how you, sorry, proteinuria, how you will quantify that, and nephrotic syndrome DD, and we have discussed renal tubular acidosis tables. So just acute kidney injury differential diagnosis. Okay, in this hypovolemia, acute tubular necrosis, intestinal nephritis, glomerulonephritis, and obstruction. Okay, just see, I am discussing the important thing. Urine sodium will be less than 20 in hypovolemia, and in glomerulonephritis. Obstruction, if it is obstruction is acute, it will be less than 20, but is obstruction is of chronic or few days, it will be more than 40. Other things, it will be more than 20. So urine sodium will be asked. Urine osmolarity, just see, more than 400 in hypovolemia and less than 350 in acute tubular necrosis and intestinal nephritis. You have to remember FANA. FANA, basically fractional excretion of sodium, is less than 1 in hypovolemia and glomerulonephritis, but it is more than 2 in acute tubular necrosis. Again, you have to remember less than 1 in acute obstruction and more than 1 in chronic obstruction. So, this is acute kidney injury table. You have to remember this. Again, we'll discuss acute kidney injury classification of global outcome. So stage 1, stage 2 and stage 3 you have to remember. First thing, just see for urine output. If urine output is less than 0.5 ml per kg per hour for 6 to 12 hours, you have to remember these. Stage 2, less than 0.5 ml per kg per hour, the value is same but it is more than or equal to 12 hours. Stage 3, less than 0.3 ml per kg per hour for more than 24 hours or anuria for more than 12 hours. So these urine output criteria are very important. Next we will see serum create criteria. Okay, serum create, if it is 1.5 to 1.9 times baseline or it is increased by more than 0.3 milligram per deciliter, it is actually stage 1. But if it is increased by 2 to 2.9 times baseline, it is stage 2. If it increases 3 times baseline or serum create is more than 4, this was previous year question, or renal replacement therapy or GFR is less than 35. Just remember, these are very confusing. Okay, serum create is more than 4 or renal replacement therapy or GFR 35. Everything will be considered in stage 3. Okay, so just remember this AKI classification table is very important. Okay, now we'll discuss CKD, chronic kidney disease, NKF guidelines. Following criteria are required. First thing, kidney damage more than 3 months. Okay, more than equal to 3 months. And GFR is less than 60 for more than 3 months. 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 So this is the important criteria, we'll discuss it. So this is kidney damage for more than 3 months and GFR is less than 60 for more than 3 months. But what are the kidney damage classification criteria? It should be structural or functional damage like abnormality in composition of blood or urine, abnormality in imaging test, abnormality on kidney biopsy. Anything will one or more is required. Okay, one or more of anything will suggest of kidney damage along with GFR less than 60 for more than 3 months will be classified as chronic kidney disease. I'm going very fast again because of time limitation, but you have to remember these. Okay, then classification stages. Just remember stage 1 is kidney damage with normal or increased GFR, means GFR is more than equal to 90. In second case, it is 60 to 89. Third stage, 30 to 59. Fourth stage, 50 to 29. And fifth stage, less than 15 or dialysis. So this is kidney failure. This is mild, this is moderate and severe. Again, you have to remember, revise this table again and again because this is classification you have to remember. Okay, so in this table we have discussed this slide we have discussed AKI classification, acute kidney injury criterias, CKD criteria and classification. This is ultra important. As we discussed earlier also, this is a part of test series NEET Pediatrics available at pediacademy.com and dedicated app. The description and link are available below the video. Okay, so in urology part, risk factor of UTI, basically they'll ask female anatomy, age less than 1 year, VUR, voiding dysfunction, constipation, and neurogenic bladder, pregnancy. I have just highlighted important one. They'll ask in these. Okay, grading of VUR is very important. First is VUR in non-dilated ureter. Ureter is non-dilated. Just see. Grade 2, VUR in upper collecting system without dilatation. So it is an upper collecting system without dilatation. Okay. Grade 3, VUR in dilated ureter and or blunting of calyces fornicis. So this is blunting will be seen. Okay. Grade 4, we are in grossly dilated ureter. Okay, so this is grossly dilated ureter. And grade 5 is massive VUR with significant ureteral dilatation, tortuosity and loss of papillary impression. So this is tortuosity plus loss of papillary impression. Okay, so they will ask grossly dilated. These keywords you have to remember. So just I am highlighting keywords. Okay, so these are the keywords: loss of papillary impression. Okay, then ureter blunting of calyces fornicis. So they will ask in exam. They will give you image and they'll ask classification of PUR. Okay, so recommendation of febrile UTI in infant, what are the guidelines? Many guidelines are there. NICE guideline, American Academy of Pediatrics, ISPN guideline, Spanish Association of Pediatrics and Swiss guidelines. Basically, in this scenario, we'll see American Academy of Pediatrics, they'll say do sonography, ultrasonography. If USG is abnormal, then do VCUG and they are not suggesting of late DMSA scan. Again, very important. ISPN guidelines, they are saying do sonography. If sonography is abnormal, non-E. coli infection is there or febrile recurrence is there, do VCUG and they are advocating late DMSA scan if grade 4 and 5th VUR is there. So just remember these two guidelines. NICE will discuss later. Okay. So basically, yeah, we have discussed classification of VUR. So it is primary or secondary. ठीक है. So primary is congenital incompetence of valvular mechanism and second with other UPB malformations. Secondary due to increased intravesical pressure like neuropathic, non-neuropathic bladder, secondary to inflammatory process and secondary to surgical process. So you have to remember classification of VUR is classified as primary or secondary. Then etiology of antenatal hydronephrosis. So this was a NEET SS question asked twice. Most common cause of uh, antenatal hydronephrosis is transient, not any pathology. Second is uretropelvic junction obstruction. Third is VUR. Okay, so these are the other regions. Other regions or Crohn belly syndrome, cystic kidney disease, congenital ureteric stricture, and megalourethra. So these are the regions. Definition of antenatal hydronephrosis by anterior-posterior diameter is again very important. If it is mild, moderate and severe, the cutoff are based on trimester base, second trimester, third trimester. Just remember in second trimester, the values are 4 to 6 millimeter, 7 to 10 millimeter, more than 10 millimeter. In third trimester, values are 7 to 9 millimeter, 10 to 15 millimeter, more than 15 millimeter. So you have to remember all values of this APD diameter of definition of antenatal hydronephrosis. So in this slide, we have discussed risk factor of UTI. We have discussed VUR grading classification. We have discussed the nice American Academy of Pediatrics and ISPN guidelines for febrile UTI, classification of VUR, antenatal hydronephrosis, APD diameter classification, and etiology of antenatal hydronephrosis. So just go through these once again. So in this week we have discussed or we have organized tests with hematuria, proteinuria, AKI, CKI, and tubular disorders urology table discussion. So basically these MCQs of these tests are a gold mine because they are 100% Nelson based. Okay, so we'll discuss Society of Fetal Urology grading system for hydronephrosis. Just see, grading of hydronephrosis are 0 to 4. In this, renal parenchymal thickness is normal everywhere, but if in question they are mentioning renal parenchymal thickness is thin, then it is grade 4 hydronephrosis. Central renal complex, we will see if it is intact 0, slight splitting 1, evident splitting 2, wide splitting 3, and further dilatation of pelvis and calyces it is 4. So this you have to remember. Okay, then grading of renal injuries, sometime they ask. So grade 1, this is renal contusion or subcapsular hematoma. Grade 2, it is non-expanding perirenal hematoma less than 1 centimeter of parenchymal laceration. Grade 3, it is more than 1 centimeter parenchymal laceration or non-expanding hematoma. Grade 4, laceration extending into collecting system with urinary extravasation. And grade 5, it completely shattered kidney by definition, multiple major laceration more than 1 centimeter. Okay, next we'll discuss some therapy of urolithiasis. If we are seeing hypercalciuria, calcium is more, then reduction of dietary sodium is required. Dietary calcium at RDA and thiazide diuretics. I'll be discussing initial treatment. Second line treatment I'm not discussing. Hyperoxaluria, reduced dietary oxalate and potassium citrate. Hypocitric aciduria, potassium citrate will be initial management, and cystinuria is alkylation or reduction of dietary sodium. So reduction of dietary sodium is mentioned in hypercalciuria and cystinuria. This was previously asked in TSS question. Again, surgical option of stones are available if renal stones are less than 1 centimeter. Okay, so shockwave lithotripsy is most common up to 1 to 2 centimeter. And if it is more than 2 centimeter, go for percutaneous nephrolithotomy. Okay, if it is in lower pole, so if it again if it is less than 1 centimeter, shockwave lithotripsy is most common, but if it is in more than 1 centimeter, percutaneous nephrolithotomy is most common. And uretral, again if it is in proximal, most common is shockwave lithotripsy. If it is distal, ureteroscopy is the most common modality of primary surgical treatment. So this was it for renal table discussion. So this is very important. Just revise them again and download our app You can revise them at app also, and pediacademy.com is also available. Hope this video is very useful to you. Many questions are expected out of it. Just go through these tables again and again, revise this video, and 7 to 10 questions at least are expected from this discussion only. So